My name is Scott Atlas. I'm a senior fellow at Hoover Institution, and I work on healthcare policy, particularly the role of the government versus the private sector in cost, access, quality, and innovation. And many people ask, what is single-payer healthcare? And the term really means when the government, usually the federal government, finances all of healthcare via the tax revenue that it collects from the citizens. Typically, single-payer is used to mean nationalized health insurance. And that is a specific situation where the government is the dominant or actually the sole insurer of healthcare. And by being the insurer of healthcare, the government therefore determines what healthcare is available, because that's what will be paid, and how much each healthcare incident will be charged, because they're doing the paying. So in that sense, the government, as the insurer, controls all access to healthcare. The extreme of a single-payer system is socialized medicine, which means that the government is the insurer and the doctors are employees of the government system. Many people believe that since other countries rely on single-payer healthcare, we in the United States are not giving the option for healthcare and are leaving our low-income Americans out of luck to get healthcare. Well, that sort of belief highlights a few very important misconceptions about what other countries' single-payer systems have. Single-payer systems are really systems that in other countries label people as insured. That does not necessarily mean they have access to timely or good quality health care. In fact, we know that in the single-payer systems that we're most familiar with, like the National Health System in England, for instance, there are really unconscionable waits for care that imperil patients' health. In fact, Americans never have these sorts of waits, like 20% of people who need urgent care for cancer wait more than 2 months to get their first treatment, or 20% of people with brain tumors wait 4 months to see a neurosurgeon. These kinds of waits are not ever experienced in the United States, with or without insurance. Second point is that we have our own system of single payer here, and we should learn that that is not the solution because we have it in the VA. And in fact, ironically, the solution to VA problems and long waits is to make available private care. And the third point I'd like to make about the single-payer systems is that those systems in other countries, to solve their problems of waits and poor outcomes and lack of access to drugs, what do? They take taxpayer money and they provide private care. They either do it in their own country or in even some instances even cross borders and use private care in other countries because of their own failures of single-payer care. The real answer for low-income Americans is not to duplicate the failed systems that we see from countries with decades of experience with single-payer. The solution is to provide access to the excellence of American medical care for low-income Americans. And that is why I propose to have Medicaid be a bridge to private insurance. We know that broad access to medical care comes from private insurance, not government insurance. And so the goal here is to let all Americans, regardless of your income status, experience the excellence of American medical care. People ask, what role should the government play in health care for low-income Americans if we don't want a single-payer system? And the answer lies in the fact that we don't want this perpetuation of a parallel system for low-income Americans that we have now with our Medicaid program. Instead of spending $500 or $600 billion a year on a system that people with money would never want to use, we want to provide access for low-income Americans to the same excellent medical care that everyone else has. And that is done by taking that money and using it to create a bridge to private insurance and even potentially some of that money toward health savings accounts so that low-income Americans can access the same doctors and hospitals that accept private insurance, the same doctors and hospitals that don't accept new Medicaid patients. Many people commonly say, well, the U.S. doesn't have a high life expectancy or infant mortality rate compared to other similarly developed countries. Doesn't that mean our healthcare system is worse? And actually, those statistics are quite misleading. They're very coarse. They have very heterogeneous inputs. For instance, if you take life expectancy, there are dozens of factors that determine life expectancy that have nothing to do with healthcare quality. Just as one example, if people die from a homicide or a suicide or a high-speed motor vehicle accident, you can't ascribe that death to poor healthcare quality. And in fact, this research was done in Iowa about 10 years ago, where the OECD nations were standardized across countries for the U.S. rate of death from suicide and homicide. And instead of the U.S. therefore ranking very low in life expectancy, the U.S. shot to the top of the chart with the best life expectancy. And the other factors that go into life expectancy depend on lifestyle. The U.S., for instance, has a totally different culture on medical care. As just one example, we do full court press in someone who's end of life, unless the patient or patient's family has opted out of that actively. We do full court press on the most premature infant. Other countries don't necessarily have that kind of medical culture, I would say. And the same logic goes to infant mortality, where we know that the countries of Western Europe, for instance, similar countries in many ways to the U.S., they don't define a live birth the way we do. We in the U.S. use World Health Organization definitions, which means any sign of life at birth of any part of a baby delivered from the mother at any age, including a single respiration, a single heart rate. Other countries in Western Europe, for instance, don't count as a live birth severe premature babies, severely premature, or babies of extremely low birth weight. And of course, these are the babies that usually die, and so therefore you have a distorted infant mortality statistic. Why don't we use just Medicare for all? That's a very common question. In fact, that's one of the proposals coming out of the Democrat Congress. The answer is actually related to what people mean by the question. The first part of that is that the question means, why don't we have single-payer government-run health care for all, since it seems to work for the seniors who have Medicare? And the reality is, first and foremost, we look at other single-payer systems. I think we all should know by now that after 65 years of the NHS in England, or decades of experience in other countries with single-payer systems run by the federal government, that people's access to care is worse than what we have in the U.S. People's outcomes from medical care are worse. There's significant delays in access to specialists, to drugs, to life-saving surgeries. And in fact, there's not a single way that single-payer systems are better in reality than what we have in the United States. But if you really look at Medicare specifically, what we know is that Medicare is indecipherable in terms of even understanding what part of Medicare you're using. It's grown to be this very complex hodgepodge of coverage for inpatient care, outpatient care, prescription drug care. And in the end, people end up being dissatisfied with Medicare. And why do we say that? Because we know the overwhelming majority of Medicare beneficiaries also purchase private insurance. This is one of the great unstated facts of Medicare. Very few people, less than 20% of people on Medicare, rely solely on traditional Medicare for their insurance, even though they think or say that they're happy with Medicare. I think the other thing we have to realize is that Medicare, as many systems that are run by the government, many programs, has a tremendous amount of fraud, abuse, and waste to the tune of $60 billion a year. When you have one system run by the government without any competition, you start having not only monopoly power, but tremendous problems of implementation like waste and fraud. We know Medicare is very good for one thing. It's at the top of the charts for denial of claims, as opposed to the private insurance companies that we hear constantly negative information about. Medicare, not the private insurers, is the one that rejects a higher rate of claims than other programs from private insurance. So in the end, people don't really understand what Medicare is when they ask for Medicare for all. But we know one basic and very fundamental fact. When consumers have choices, it's better for the consumers. And an absence of those choices is harmful. And this is shown even in the medical world, where when we have large conglomerate hospitals, when we have practices consolidating, when we have single types of insurers on the Affordable Care Act exchanges, when there's less competition and less choice, consumers don't benefit, consumers are harmed because the price of medical care actually goes up. You may ask, isn't it true that government is the only way to hold down healthcare costs? And the reality is that the only way government holds down healthcare costs is by restricting the use and access to healthcare. That's precisely why systems with government-run insurance or socialized medicine in the extreme have far longer waits for care, less access to drugs, less access to new drugs, delays for appointments for specialists, and all of these things translate into worse health outcomes. And that is filling the medical literature, the worst health outcomes of single-payer systems compared to U.S. healthcare is quite remarkable for every major disease, every major cancer, and every chronic disease. And so in the end, when you have a way to hold healthcare costs down by top-down decree, the only way to do that is restrict access to care. The real way to hold healthcare costs down is to get costs down like we do in every other good or service in the United States, and that is to have facilitated competition of the seller, in this case, the healthcare provider, and an incentive by the consumers to seek value for their money. And if you seek value for your money, that necessitates having the information upon which to judge value and having the vehicles to do that. And the vehicle to do that is to be paying for a lot of your medical care yourself. In the current system in the US, we think someone else is paying because insurance covers almost everything with very limited out-of-pocket expense. And when someone else is paying, no one has an incentive to care what it costs. Thanks for the questions, and if you have any more, post them in the space below.